Thank you, Chitanika, for the wonderful presentation. I was asked to give a real-life management of drug-drug interaction, focusing on anticonvulsants. I'll ask Dr. Foloshi to help me answer some of the questions, or Dr. Newma. Yeah, so no disclosures. Yeah, so the case that we have is a 30-year-old man with a medical history of type 2 diabetic and long COVID as well. The patient has epilepsy and panic disorder. His mental health medication includes his own Tegretol, carbamazepine, 400 milligrams TDS, which is a higher dose, and takes clonazepam, 0.5 milligrams as needed for his panic attack. He's unvaccinated for COVID, SARS-CoV-2, and this patient had COVID in the past with hospitalization and comes back with a 2-day rapid antigen positive test for COVID-19. So the first question, Dr. Newma, considering his medication, is this, would you recommend this patient to have on a COVID-19 antiviral? I think the answer is yes. Obviously, we can agree here for the sake of time. Which antiviral would you prescribe? I think that's the main question, similar to what Dr. Chitanika gave us. So we have an option of our Paxlovid, Molnupiravir, and Remdesivir. So in case you do decide to treat with Paxlovid, the drug that we have in the country, what are the following actions that you should take regarding the carbamazepine? I think that's the main question, that what would you do? We do get this question a lot, especially in the HIV program on patients that have seizure disorder. So we have options. Some people would think you would have to hold the carbamazepine for the duration when you are treating with Paxlovid and you have an extended 2 days. I think Prof. Berger did explain why the 2 days, where it's coming from. You can substitute the carbamazepine with levetiracetam, which is a newer anticonvulsant. You can also decrease, you can decrease the dose of carbamazepine by 50% for the duration of the treatment. I think it's supposed to be decreased, or you can't change anything. So what options would you take in such a scenario? I'll take you through I think most of this has been presented by Professor Berger. What drug interactions mean. There will be a perpetrator and there will be a victim drug. And obviously it has to do with either there will be an increase in the blood concentration of the same drug or reduction. So I think the take-home message from this crowded slide is, again, what has been pointed out, the use of drug-drug interaction checkers, and also the second last bullet point that you cannot take drugs as a class. You actually have to check. You have to check for each drug. You can't say, oh, epileptic drug, anti-epileptic drugs. You have to do the physical check. And these are just the P54 enzyme and some of the drugs, the substrates. We know that there will be induction and inhibition, and the drug that we are concerned with is the ritonavir, which does actually inhibit and causes elevation in the drug concentration of some of the drugs. This is very important. So we do have inducers, and the drug that we're discussing, ritonavir, is an inhibitor, and we have inducers as well, rifampicin. Yeah, but note that anti-epileptics, while they're substrates, some of them do have some weak induction, especially Tegretol itself. Actually, it does have auto-induction. That's where the correct use of Tegretol is. As you are using it, you're supposed to be increasing the dose because there's that auto-induction that takes place. So what are the things to consider? Some of the outcomes when you are having drug-drug interactions, it can be a no, you shouldn't use the drug, or sometimes there should be some reductions to take place, or sometimes the drugs, as previously explained, there's no clinical significance between the interaction. So, carbamazepine and ritonavir. So the answer is no. You know, it's in red. Again, we use the Liverpool here. You're not supposed to use it because the drug levels for carbamazepine would go up, or Tegretol, and you have to look for an alternative. So what are the alternatives that we have? And here it's interesting. You can see that there are some antiepileptics that are in red and others that are in green. This patient was also on clonazepam for the panic attack. You can see that the clonazepam is actually in red. But would you stop the clonazepam because it's in red? The patient was taking the clonazepam for panic attack in an intermittent way. Yeah. So a drug that probably you are not taking always like that, there might be no need. For instance, if the patient was taking the clonazepam every day, you probably have to replace it with a short-acting drug, benzodiazepines like maybe lorazepam and so on, because clonazepam's half-life is very long, maybe like 7 days. So the drug levels will really go up. Yeah. So it would make sense to probably use a newer antiepileptic drug in this case, like levetiracetam or others that are in green, or things like pregabalin and so on. Yeah. But is that the correct choice in this scenario? We'll look at that. Remdesivir and carbamazepine, no interaction, mild interaction, but you can still use it for the reasons that have been given in the previous presentations. Molnupiravir, no interaction at all with the drug that we'd like to use. So, what would be the verdict if I was seeing this patient? I don't know what others would do, but you have some options. Probably you would start the patient on remdesivir instead as opposed to Paxlovid, but you have to struggle with the fact that remdesivir is an injectable. It comes with its own difficulties and so on, especially if the patient won't be admitted. The second option is probably to replace the carbamazepine for that particular time with a drug that works better. In our environment, it's not levetiracetam, it's not a drug that is readily available. Even the other options like pregabalin. But you have to put the patient's situation and the health system situation in perspective. So in conclusion, mental health conditions are actually very common in our country and elsewhere, and the severe mental health conditions are associated with high risk for COVID-19 for various reasons, and we need to remember to manage these patients when they do get COVID well. But you really have to consider the patient's circumstances and also the health system circumstances, the length of treatment as it was with someone receiving clonazepam in this case. And remember, as we've shown, to use a drug checker like Liverpool's COVID-19 drug checker, you have to go for that drug as opposed to picking the class of drugs. With that, these are some of the references that I used, and thank you very much.